Our last lecture for block 1. Is that better? You guys carrying on? All right. So we have last lecture for block 1. So we'll do our review on the Wednesday we get back from the 4-day. So I highly encourage you to get familiar with the material, go through it a few times. And then that Wednesday review will be to figure out what other things you might want to touch base with for Friday, next Friday. And then obviously, my office is down next to Commander Boz. I have my cell phone on the syllabus, so if there's anything, please not the night before. But if you have to, go ahead. But just text me, that's probably the easiest way, or my email. If you have any last minute questions, or any clarification, I'm happy to go over stuff. I'm not going to tell you the test questions. But I'll definitely, help you, help to ensure that you understand it the way that I want you to understand it, right, for the test. All right, so this is our last topic. So we're talking about sleep apnea. This is a huge topic in the military. This is one of those, everybody wants to get tested right around in retirement so that they can get their points. And then the other topic we're going to talk about is a disease called obesity hypoventilation syndrome. All right, so this is the overview. This is going to go and talk a little bit, it's going to bring us back to our physics of breathing. We have ventilation, which is the movement of air between the lungs and the atmosphere. And then you have oxygenation, which is the air exchanging down in the alveoli and getting into the bloodstream so we can eventually get into the tissues. Tissues put CO2. So again, when you get your ABG and your CO2 is really, really high, then you need to consider maybe you got a venous sample. Brings it back to the lungs, does the exchange the other way, and then we ventilate that CO2 out of the body. It's an excellent system when it works. And then we have, again, definitions. So when ventilation, when there's problems with it, we've got apnea, which is cessation of breathing. So someone who's apneic is not breathing. And then we've got hypo, which means not enough. You're not breathing enough. You're not ventilating enough. And so your body is filling up with carbon dioxide. So hypoventilation. Causes of hypoventilation, remember we had our last lecture, we talked about COPD. So that chronic inflammation of the airway, increased mucus production, decreased cilia function, decreases the diameter of the airway, causes obstruction, makes that FEV1 FVC ratio go down on your PFTs. And you're not ventilating enough CO2 out of the body, and so that starts to build up. We're going to talk about oxygen supplementation later on in block 2, and we'll talk about specifically when patients have COPD and why it's important to know that before you decide how high to try to get their O2. Another reason of hypoventilation is a mechanical reason, obesity, and then we've got other things. We talked about our classic ABG, where patients, breathing 4 or 5 breaths per minute. They're obtunded. You get an ABG. Their pH is dropped. Their CO2 is high because they're not breathing enough times a minute in order to get enough CO2 out of their body, so they become acidotic. And then other reasons, when we see people that have neuromuscular disorders, they become, as it progresses, they become confined to a wheelchair, and then a lot of these patients eventually have to become intubated, and that has to do with just their chest wall not being able to perform the functions physically. Physics, right? You need to have that chest wall be able to expand and contract in order to create that pressure change, which then allows air to flow. All right, so the first one we're talking about is obesity hypoventilation syndrome. I don't think I have this picture in the lecture, and I don't want to offend anybody. I should caveat with that. But there's a picture that whenever I think about obesity hypoventilation syndrome, I always think about this picture, and then it helps to solidify. Sorry, should have pulled it up. So it's right here. And this is the picture that I always popped in my, and when I saw this episode, I was like, all those guys have obesity hypoventilation syndrome. And I don't know if you remember, they were all kind of very labored breathing, very slow, and it's because all of this weight is sitting on their chest, and it's impeding that nice, normal airflow. Again, that relies on pressure differences. And so you're introducing a new pressure to the system that is making that less, they have to put more effort into it, right? All right, but the primary disease here is typically the obesity. All right, get back to our lecture here. I should just put that in the lecture, but I'm afraid at some point I'll offend somebody. But that's the thought I put in my head for that kind of quintessential person that would have this. So the risks, we'll talk about signs and symptoms, diagnosis, treatment. There's another term for this. This is the term that I learned. So I learned it as Pickwickian. I didn't learn a lot about it because I went to med school in early 2000. Even though obesity was a problem, I think now it's become more prevalent of a problem, and therefore it's more important for people to understand it because you're probably going to see it, especially in certain areas and certain populations. So the way we describe this syndrome is you have increased weight on the chest, you have fat deposits around the neck that push them on that posterior airway, and as a result, you're unable to successfully expand and contract your chest in order to adequately ventilate. So you're not breathing frequent enough because of this external load. So your PFTs will show a restrictive pattern. So the lungs are not able to fully expand and decrease. Not so much obstructive because unless they have concomitant COPD, then the air can move in that trachea and in those bronchi. It's just that the chest cavity cannot expand. So you'll see a restrictive pattern. And I just answered the question for you. All right, signs and symptoms. So patients will have sleep apnea. And if we remember the term apnea, it means a cessation of breathing. That means patients have a cessation of breathing while they're sleeping. That's all that means. That's what sleep apnea means. So patients will snore, their sleep will be disrupted. It will present very, very similar to what we're going to talk about in the next section, obstructive sleep apnea. They'll be very tired during the day, they'll wake up, they'll have headaches, poor concentration. So when we talk about the checklist we use when we're evaluating for sleep apnea, this will apply to this one as well. The other requirement, and we'll talk about diagnostic criteria, is obesity. So the patients will be obese. It's in the definition, right? So it will be part of the diagnostic criteria. This red arrow pointing to this word down here, this is what differentiates it. This is what differentiates it, is that during the day, it's not just at night when they're sleeping and laying down, but this obesity, right, is with them throughout the day, and so they will have daytime hypoventilation. This is what differentiates it. So if you draw an ABG on this person during the day, as opposed to obstructive sleep apnea, they might have normal ventilation during the day, it's only when they lay down. This one, they will have hypoventilation during the day. Oh, I did have a picture on there. Dang it. All right. So all the following are required. Remember, all of the following. So if one of these doesn't exist, remember we said all of the following were required to call it a normal ABG, right? So all of the following, you have to have all of these in order to make the diagnosis. The other thing I want to point out is this is a diagnosis of exclusion. Does everyone understand what that is? That means you've ruled everything else out. You've assessed for everything else you could possibly think of, and this is the only explanation left on the table. So, their hypoventilation is not from COPD, it's not from a neuromuscular disorder, there's no meds they're taking, and then obviously there's no other chest wall disorder that's causing So how do we treat it? Okay, so here's the criteria, right? We didn't really go through those. So they have to have sleep apnea. They have to have the sleep study, cessation of sleep during the nighttime while they're sleeping. Their BMI has to be over 30, and then they have to have demonstrated episodes of hypoventilation during the day, which is described as hypercapnia. So PaCO2 will be over 45 during the day for these patients, without anything else going on. It's just their normal baseline. And then again, diagnosis of exclusion. How do you treat it? Obviously, you have to lose weight. CPAP is included in this treatment algorithm as well. So talk about CPAP a little more detail when we talk about obstructive sleep apnea. And then critical is to avoid anything else that suppresses the respiratory drive. This is a huge risk factor for people basically suffocating in their sleep. They drink a lot, they take opiates, they take sedating meds, they take an Ambien, they drink 4 beers. Patients that already have a decreased respiratory drive, that already have mechanical problems with ventilation, unfortunately, this can lead to people passing away overnight because of this. All right, so why do we care? With a high mortality rate, if this remains untreated, the same way that we talked about COPD, right? You still need to have things circulate. We talked about heart failure, left-sided heart failure from things like hypertension, but you can also have right-sided heart failure because the pressure is too high in that pulmonary vein heading back to the heart, which is full of oxygenated blood. So it'll back up, and then when the blood is trying to be pumped from that right heart to the pulmonary system in that artery, it'll push back and then it'll cause changes on that right side of the heart. And then eventually the left side of the heart. All right, so that was obesity hypoventilation syndrome. So obstructive sleep apnea. Again, the name implies, so in the picture on the right here, we have a normal airway. And when we have obstructive sleep apnea, while you're sleeping, those pharyngeal muscles relax, and essentially that pharynx collapses backwards during inspiration. That's what causes that, that lovely sound that we hear at night in some of our spouses. My husband had the biggest win about 2 months ago. And we were at a hotel or something, and I heard this like awful snore, and I just went like this really hard to him, and I hit him, and I looked over, and he was sitting up looking at his phone, and I was like, oh, that was me, and he was so happy though, because I always tell him, you were snoring last night. He's like, yeah, it was me. You weren't waking yourself up snoring. It was an awesome win for him. I have to keep giving it to him over and over again, because he doesn't get many. All right, so again, there's pharyngeal muscle issues. Anatomically, we'll talk about the Mallampati score. You guys have learned about that. If not, you will definitely learn about it in EMED. The Mallampati score is a way that medical providers communicate the patency of an airway. So if you've ever heard the term difficult airway, that means that patient has a high Mallampati score. That means if you have them look in their mouth and you say ah, all you see is a soft palate, maybe a hard palate and a tongue. And after you've looked in, I always tell my clinical group, I have the same thing I do every week, so I've looked in a lot of people's mouths, and I've gotten really good at it right away. Some of them you can see all the way to their soul, right? You can see that whole posterior pharyngeal wall. It's nice, that'll be an easy innovation probably. And then you've got those guys with the real thick necks, real short necks, and they open their mouth, and literally you can see past their teeth and maybe hard palate. So. Those patients will definitely be at higher risk for developing sleep apnea, obstructive sleep apnea. Again, just like we talked about, if people drink, if there's any sort of sedating medications involved, it's going to make it worse. These are the symptoms they're going to present with. So lots of snoring, This is a mechanical upper airway obstruction when they're in the prone position, or excuse me, supine position. Snoring, snoring, snoring. There'll be episodes where that obstruction stays in place for a minute, so they actually stop breathing, so apneic episodes. And then their CO2 will go boop, 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 and finally it will force their body to, take another big gasp of air. It's not, what do we talk about, that end of life agonal breathing at the end of life? It's not that, but it kind of sounds like that sometimes, right? Where people sound like they're gasping for air, gasping for life. And just like that, obesity, hypoventilation, lots of fatigue in the morning, headaches, just everything that goes with not getting refreshing sleep. You'll be tired during the day. This hypertension, so we had a clin court case where a patient presented with a high blood pressure. One of my students kicked ass and kicked butt, and came up with that as a possible secondary cause. So definitely, when you have patients with hypertension, as you're making the diagnosis, you should ask a few questions to see if you need to get a sleep study on this person. So tools you can use in the clinic. Remember when I remember seeing this a lot in the clinic, because the first time you're in a clinic where you're taking care of service members, especially around retirement, you will have a lot of them wanting to get sleep studies. So try to get yourself a good tool to at least have a way to do some sort of screening. Now this is subjective, so patients can lie, right? They can just, and they will, they'll figure out what they need to say to get the study. That's okay. But you still want to do due diligence to make sure that you're at least trying to get a clinical probability. You just don't want to say, what was the indication for the study? The patient wanted it. No, that's not. Their sleepiness scale was above 10, right? They're something. So use tools. There's another tool I think I have later on here where we actually use the bed mate, right? So if I really didn't think somebody needed it, I'd ask the person sleeping next to them, now everybody has the apps now, right? So they can just show you. But back in the day, it was, you brought their spouse in, whoever slept in the bed with them. Because somebody could say, I stopped breathing at night. Well, how do you know? It's a little bit easier now because people have the apps. All right, we talked about, so what are you going to do? So you're going to ask questions, you're going to get a history, any snoring, how tired are you during the day? You're going to do an exam. It's always part of our evaluation for this. In general, you may not find anything. Patient may, on general appearance, appear sleepy. You can note that. When you look in their throat, which you should do on all these patients, you may see a smaller airway, excessive soft tissue, anything that can flop down when that patient's laying back and obstruct that airway. Obstructive sleep apnea. Anything in that airway that doesn't look nice and open and patent, excessive tissue, a lot of tonsils, uvula, all that. Just note that. Look up their nose, see how congested they are, see if there's any obstruction. If your mouth closes at night, where else can we breathe through, right? And then assessing their blood pressure, that's part of our physical exam. This is that Pulm I was talking about. Don't memorize this boring. As you start to do clinical exams, when you're in phase 2, just put it in the back of your mind, because when you start to do innovations, this becomes a good way to communicate why you're asking the, anesthesiologist to come down and do the innovation, right? They've got a melancholy potty 4. I've done one innovation in my entire life, so I would love for someone else to come down. And when you do pre-ops, I think that's usually part of the pre-op report too. They're going to look anyway, but it's good practice. Okay, this is another screening tool. Something that I use is a little cheat sheet when you go in and sleep apnea is in your differential. Just gives you a couple things that you can ask. Do you have any of these? Do you have daytime somnolence? Do you snore loudly? Do Do you have observed or evidence of apnea, that you stop breathing at night? Are you hypertensive? Are you overweight or obese? How old are you? What's your circumference? Are you a male? Are you not a male? If you look at that, a score greater than or equal to 3 is positive. So this can all be positive based off subjective information. So people can say, yes, I snore loudly, yes, I'm tired during the day, and yes, I have observed apnea, right? And they can still screen positive, i.e. you still send them for the test. That's okay, I'm okay with that. I just want to make sure that every single person gets asked the same questions, so that there's at least some screening going on. This is the sleep study. Has anyone ever had one here? You don't really sleep, right?
I was in Japan, so.
Yeah. They got you to sleep nice?
Yeah.
Yeah.
There's a bunch of wire they put on my head.
Yeah.
And, all of them.
Yeah. So this is what it is. I don't know. I would never be able to sleep with that. There's no way. I would have to do whatever the ETOH, opiates, and sedating meds probably. I just don't know how people sleep on this. How this is objective? Because now maybe there are options at home where you can get these done at home. If you're talks about it down here, if you don't have a lot of comorbidities, if we're not worried about looking for anything else. So what this does, it's very comprehensive. So when you get the studies back, you get a ton of information. They do an EEG during it, they do an ECG during it. So you get a lot of very useful information. In terms of using it to diagnose sleep apnea, we'll show you specifically what it measures and how we use it to make those diagnoses. But you can identify cardiac dysrhythmias. We're looking at the O2 all night. We're looking at any time that patient stopped breathing, respiratory effort, airflow. So lots of good information in order to make clinical decisions. All right, so there's this thing called the AHI. And this is what your report will show you. I'll show you what a report looks like on the next slide or the one after that. So they will give you an AHI. And the AHI will be from 0 to, I forget what it goes up to, but it goes up pretty high. So it's looking at how many times you stop breathing, what your O2 sats are. So apnea, hypopnea index, how many times you stop breathing or slowed down enough that we counted it each hour. 0 to 4 events, we call that normal. Over greater than or equal to 30. That means more than every other minute you're spent in either breathing too shallow, not breathing enough, or not breathing at all. O2 sats can be low during those periods of time. So other ways. Some of the testing purposes will focus on that side. And then usually this correlates to the impact on the patient. So a patient comes in, they're like, I basically want a sleep study because they told me at the VA to get a sleep study before I get out. Fine. Maybe they do snore, maybe they, like anyway, you send them for it, right? Their mom potty was 1, they're otherwise healthy, they're not obese, they're a 40-year-old male, and you get back 0 to 4 events, say that's normal, you don't have sleep apnea. And it's fairly objective. Then you get into this mild, moderate, severe. Usually when you're in this normal to mild, may not impact your daily life, but the patient's family usually notices, partner and bedmate, right? Because they snore. So moderate. Go ahead.
Could this ever be interfered with by like seasonal allergies? Because like I know there's people that like will snore during certain times of the year because they have more congestion.
Mm-hmm. Yeah. So there's certain medical conditions where you're functioning just fine, and then something else on top of it, right? So a perfect example of that's asthma. So you can be at your baseline for asthma and not really have any symptoms, maybe use your inhaler once in a while, and then you get a cold, right? And so it can exacerbate, in this case, not a medical issue, meaning whatever the pathophysiology of asthma is, but a mechanical issue where a little bit of extra inflammation actually pushes the patient now to be perceiving those symptoms. Someone can have sinus issues, right? Someone can have knee issues, and then something precipitates kind of a flare of that, right? And absolutely, so so when we talk about treatment, right, I think we touch on that in terms of there's certainly treatments. We'll talk about the machine, but at the same time, there's other things that we do to help minimize the effect of the symptoms. Don't take sedatives. Don't smoke. And we'll talk about that when we talk about treatment.
I was curious if it could cause like a false positive, like scenario.
To make them stop breathing more times. Yeah, I mean, I think they're pretty good. People can certainly take these on 2 different nights and have very different results, depending on other comorbidities or other things that are going on. But as terms of like a false positive, I think if someone didn't have sleep apnea, didn't have obstructive sleep apnea, and it was allergies, I feel like maybe we'd get them up into the mild range, maybe. And so could we be putting someone on a CPAP that didn't really need it because it was just allergies? Potentially, that's our job,
Okay.
is to differentiate it, you know, and see what those comorbidities are. What could be causing that? But certainly, yeah, that could be a differential for this. All right, so this is an actual study. This is what I love, and I hope they still do this for you guys. I used to love this in residency, because when you get the report back, they actually tell you how to treat it. So that was always really nice, because I would just do whatever it said in that report. Because there's an actual clinician, right, that writes these reports. So if we look real quick, we talked about that AHI. So this patient had 74 apneic or hypoapneic events per hour, which is a lot. I've seen these before. I don't know how. I actually probably could have diagnosed with several people in my unit when we used to have to sleep in those big bays. And it was just like, here, all night. And I'd wake up and I'd be like, you need a CPAP, you need a CPAP, you need a priest, you know, all night. And you know, you're like, these people sound like they're dying. And so again, certainly, I've met several patients who went undiagnosed, got diagnosed, got a CPAP, and were like almost emotional about the change it made on their life. You know, they were on antidepressants, they were on whatever, name it, because of this overwhelming fatigue. And they finally got on treatment and literally got a renewal on life. Wake up feeling rested, like, holy crap, that can change your entire existence. It can ruin you and it can make you feel like $1 million. So, but 74 is a lot. So obviously if we come down here to the impression, we expect to see severe and we see it. Just a little more detail in there, right? The patient spent 91 minutes with an oxygen sat below 90, so that was an additional criteria that we had talked about. But this guy, you know, for testing purposes, we'll focus in on that AHI. That's the thing, you know, that's the stuff I want you to memorize. The rest of the stuff you'll remember when you start doing this in clinical practice. All right. So, surprise, surprise. Looks about the same to hyperventilation, right? Very, very similar treatment. Mild, I'll show you what these look like. These are options, just to help the mechanical airway, keep it open at night, keep it patent. Talk about the CPAP, that's the gold standard. In fact, if we looked at our report, right, so positive airway pressure. It even gives you the titration. This is beautiful, right? Not that you'll be doing that, but it's just nice to see it. Positive airway pressure. So that means a little bit of extra pressure in that airway just to keep it open. Keep that airway from completely collapsing and causing those apneic episodes. And then we have the C in front of it, that means continuous. So, this positive air, remember we talked about the sighing every 90 seconds, right? You're breathing along and then every 90 seconds we go, so that's a little bit of positive airway pressure, right? We use that chest wall. Here, we're using a machine to push that pressure in. We don't want it to be too high, right? There's a thing called barotrauma. Put too much pressure in there and we blow things out. We don't want to do that. And you have air getting into the chest cavity. So these are those little machines they wear. Now they got these little implants. Alright, it's kind of similar, but not really sure how those work yet, totally. I've seen them on commercials. They look very, very interesting. I don't think the military is using them yet, but I'm sure by the time you're getting ready to retire, hopefully, we'll be using those as well. Rather than having people carrying around their CPAPs all the time. You know, we've got, again, BiPAP, a lot of different PAPs we can use. So interestingly enough, we don't add, even though we're worried about the hypoxia at night, we don't add oxygen. So the thing about oxygen is, when your CO2, when we talk about oxygen supplementation, when your CO2 gets too high, there's a threshold. And when you reach that threshold, you take a breath. Right? That's how the body works. CO2, boop, 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 and then you breathe. And so if we don't want to give too much O2, right, because then we kind of trick the body, it takes longer to get to that threshold, and so we actually make the apnea a little bit worse. And this is just our standard obstructive sleep apnea patient. When you get into critical care and all that fun stuff, I'm sure it'll be a whole different ballgame. But these are the ambulatory outpatient obstructive sleep apnea. It's just pictures of the devices, help to bring that airway forward, help to keep things patent at night. Some information on the CPAP. Again, we've come up with some newer tools now, some newer devices. Much better tolerated because most of the problems with this is people hate it. And they think their sleep was bad with just OSA. Then you put this machine on them and people wouldn't clean it right. And they'd get, respiratory fungal infections and things like that. So a lot of people wake up and they're like crooked on their head. There's a little bit better devices now where they just cover the nose. I have pictures of that. They've gotten better and better and better. And for us in the military, unfortunately, we just have to see what the military is going to pay for. So it really is dependent on where you're at. All right, so this is another, I did like a 2-week or 3-week rotation with ENT, and I think they just kept giving me all the UPPP patients. These are patients that have sleep apnea, and they've got crappy melanopodes, and so they'll actually, the ENT surgeons will actually go in and take that soft palate and UPPP off to open up that airway. You will see patients like this, especially when you do internal med. Don't gasp or anything, but you'll look in their airway and you'll be like, they don't have a uvula, right? And it'll be like this nice clean line along the hard palate, and that means they've had the procedure, and this could cure their sleep apnea without needing to wear the sleep apnea machine CPAP. So it's a good option, especially when we know someone's airway is crap, and this could cure them, really, in some cases. Nasal septoplasty, so when we're talking about something in the upper airway, you can get some, OMFS can come in and do some mandibular maxillary surgery. And then when we get really excited, this is where these new devices are coming in, where we actually go into the hypoglossal nerve, stimulate that, and that acts to open the airway as well. So, important slide, just to keep in mind, there are a lot of comorbidities associated with having sleep apnea. There's a lot of things that increase the morbidity, right? Having hypertension, sleep disturbances, headaches. So that's morbidity, but mortality. You ever seen the study they did on the drunk people versus the tired people behind the wheel? Fascinating, right? They did this side-by-side study, and they got people drunk and got behind the wheel, and then they made people sleep deprived and got behind the wheel. And by far, the sleep deprived people were way more dangerous on the road. Huh? Yeah, no, don't justify drinking and driving. You're like, well, at least I'm not tired. No. But sleepiness on the road it's very, very dangerous. And I remember leaving residency a couple times and waking up at a stoplight with my foot on the brake. Because I had stopped at the stoplight and went and passed out to sleep. So. Alright. Oh, we got a long time, huh?